So, good evening, all. Hope I am audible, and I'm happy to welcome you all for this new session from our DocTutorials team for surgery residents. And from now, every week we will be having a topic for discussion, and this will be helpful for you people in exam and also in theory exam, also in live practical case presentation even. Okay. So the main aim of session will be helping you and guiding you in writing the essay questions. How to write an essay and how to present an essay for getting maximum marks in your exam papers. And today we will be discussing about burns. Burns is a very, very, very important topic because we are getting lots of questions from burns topic. Either we will be getting an essay question or we can also get short notes from burns even. And this burns is also a very, very important topic in your day-to-day practice even. Because we will be, as a surgeon, we'll be facing lots of burns case in our day-to-day practice even. So this session will be very helpful for you for exam purpose, scoring purpose, and also in your day-to-day practice even. So going into the question. So the question can be in either forms, like it can be like describe the pathophysiology, systemic effect, and techniques for treating the thermal burns, or this can be in any form. Okay, so always start with introduction in an essay question. So we have to define what burns is. So burns is an injury that results from the direct contact or exposure to any physical or a thermal or a chemical or an electrical or a radiation source. So burns is an injury that can be caused by any of the following source. The source includes either a physical injury or a thermal one or a chemical burns, electrical one, or an exposure to radiation can cause radiation burns. So after introduction, we will be going for classification of burns. So the burns injury can be classified based on the etiology. Okay, there are different types of classification of burns. Now we are going to see about classification of burns based on the etiology. Okay, this is not just for exam purpose. Even while receiving a burns case in your emergency room or in the triage, we have to consider these things before going for the treatment of the patient. So coming to the classification based on etiology, either it can be a thermal burns on exposure to flames or a hot substance, electrical burns on exposure to electricity or high voltage burns like thunderstorm, thunder burns, lightning can also cause electrical burns. Chemical burns, like maybe an accidental one, like exposure to the strong acids or alkali can cause chemical burns. Of course, exposure to radiations can also cause burns, that is called as the radiation burns. And inhalation injuries like inhaling carbon monoxide or some poisonous pungent gases can cause inhalation burns. This is the classification based on the etiology of burns. And we will be discussing about each type of burns in upcoming slides. First will be thermal burns. And this thermal burns is the most common type. This is the most common type. And this can be caused on exposure to either a cold or a hot substance. For thermal burns to occur, there should be either direct contact with the hot object or sometimes the hot object can even stick onto the skin even. Like if I'm getting a burns in my shirt, this will cause thermal burns. So either direct contact with the hot objects or any object which is hot or contains flame is getting sticked onto the skin can cause thermal burns. In this image, you can see the outcome of a thermal burns. So thing is that it is the most common type of burns. So this thermal burns can be caused by flame. What is flame? It is a combusting substance produces flames. So any direct contact with the flames can cause thermal burns. Can cause thermal burns. And combustible items, it may be a gasoline or it can be a wood, it can be a petrol, anything can cause flames. These flames can cause thermal burns. And what is the kind of injury these thermal burns can cause? It is called as scalding. So scalding is a kind of injury that the thermal burns can cause. The scalding can occur on direct contact with either hot liquids or vapors. This scalding can occur by direct contact with hot liquid or vapors, and this is more common in pediatric age group. Why it is more common in pediatric age group? Because when the children were playing, there can be an accidental spillage of hot liquids into their skin. That can cause scalding. Scalding was previously asked in 2 marks, but as now the pattern has been changed, this can also be asked in the MCQ also, because scalding can be caused by dash. Option A, hot liquids. Option B, hot substance or hot pan. Option C, lightning. Option D, it can be a radiation exposure. So scalding cannot be asked as an MCQ also. So next, coming to the electrical burns. Electrical burns can occur on exposure to any electrical object, and this can also occur on exposure to the lightning. On exposure to the lightning. Here you can see the clinical images. When a person touches or holds a live electrical wire, he can get an entry wound here. The electricity penetrates into the body, and this will cause an entry wound. And of course, there will also be an exit wound through which the current passes into the neutral object like ground. So this electrical burns can be further classified based on the voltage, either a low voltage injury or a high voltage injury. So any electrical burns that is caused by low voltage, that is less than 1000 volt, it is considered to be a low voltage. If the voltage is more than 1000 volt, then it is considered to be high voltage injury. This low voltage injury will cause a low energy burns, and it is less severe. That will be a minimal damage to the skin and subcutaneous tissue. And in all kind of low voltage burns, there will be an entry and exit wound. And this entry wound preferably usually in the place where we get contact with the electrical appliances. For example, if I'm holding a live wire, the entry wound will be in my hand. If I'm standing on the ground, while holding the wire, my entry wound will be in the hand, and the exit wound will be in my foot, where the current passes into the ground through the foot. So that is how the entry and exit wound occurs. Of course, there are some differences between entry wound and exit wound. Even the edges of the entry wound will be towards the inside. It will be inverted edges in the entry wound. While in case of an exit wound, the edges will be everted. Okay. So coming to the high voltage burns, this is caused by electrical burns of more than 1000 volts. This is usually due to flash burns or lightning. Lightning can cause high voltage burns. Now coming to the chemical burns, this occurs on exposure to the corrosive liquids. This can be either a strong acid or strong alkali. This can be either a strong acid or strong alkali. And the degree of damage that is caused by the chemical burns depends on 3 factors. The degree of damage caused by this chemical burns depends on 3 factors. First will be chemical nature of the agent. chemical nature of the agent, whether it is an acid or an alkali, and even if it is an acid, it is whether it is a strong acid or weak acid or an organic acid. In case of alkali, whether it is a strong alkali or a weak alkali. Of course, alkali will cause severe burns than the acids. It will cause severe burns than the acid. Why? Because acids on exposure will cause protein denaturation and coagulation, which itself will act as a barrier for the spread of the acid. The acid, for example, if acid gets in contact with my hand, on getting contact with my hand, this will cause protein denaturation and coagulin formation. Something like an eschar, fibrous tissue will be formed on exposure to the acid. This fibrous tissue or this coagulum will itself prevent the spread of the acid. This is not in case of alkali. Alkali will keep eroding. So the area of spread of alkali will be more, but acid will be self-limiting. Okay, so strong alkali will cause severe damage than the acid. And of course, concentration of the agent. For example, in case of a hydrochloric acid, strong acids will cause severe injury than the weak, low concentration of hydrochloric acid. And also the duration of skin contact. If the duration of skin contact is higher, the degree of injury will also be in the upper scale. If duration is less, then degree of injury will also be less. To the radiation injury, this radiation exposure, the radiation exposure can cause either superficial burns or deep burns. This depends on the nature of the radiation. This depends on the nature of the radiation, also the frequency in which it is emitted and duration of exposure. So nature of the radiation, whether it is an alpha radiation or beta radiation, and frequency at which it is emitted, and also duration of exposure matters. These three factors determine the nature of injury caused by exposure to radiation on and burns or an injury. So these radiations are capable of causing superficial or deep burns. This nature of injury depends on the nature of the radiation, either an alpha radiation or a beta radiation, the frequency at which the radiation is being emitted from the source, and the duration of exposure of this radiation. So alpha radiations are those that travel for a shorter distance and will have minimal penetrating ability. These alpha radiations have a minimal penetrating ability and will travel for a shorter distance. So if the distance is high, the alpha radiations will have less injury effect, will have a less effect, and penetration will also be less. So this causes superficial burns. But if it is ingested accidentally, if any substance that is emitting alpha radiation is being ingested, this can cause internal organ damage also. Coming to the beta radiation, these are small particles. These have more energy and have more penetrating ability. These beta radiations are small particles having more energy and more penetrating ability. And because of this can cause severe damage and deep burns. So beta radiations can cause deep burns because of its higher penetrating ability. Because of its deep penetrating ability, they can cause deep burns than the alpha radiations. This is about the radiation burns. Coming to the inhalation burns. So inhaling any noxious substances, even a smoke, dust particles, carbon monoxide can cause inhalational burns. And the management of inhalation burns depends upon the area of respiratory tract, upper respiratory tract involved. If the inhalation injury is above the glottis, if it is above the glottis, A simple tracheostomy is sufficient. A simple tracheostomy will be sufficient. If the inhalation injury is below the level of glottis, if the inhalation injury is below the level of glottis, patient may need ECMO even. Patient may need ECMO even because this inhalation burns will erode the respiratory tract mucosa. This can cause fibrosis and tracheal or bronchial stenosis can be the complication. So it can be the complication in long term. In long term, immediately on exposure to these nauseous gas substances, the patient will develop airway edema, which can cause respiratory compromise. So, how to secure the airway then? Of course, either by intubation or tracheostomy. Intubation, in case of any inhalation injury, will be difficult, and of course, in some cases, it is even contraindicated. So, any inhalation injury above the glottis, preferably go for a tracheostomy. If the inhalation injury is below the level of glottis, patient can even need extracorporeal membrane oxygenator for management even. So coming to the classification based on the depth of the burns. Till now, we saw about the classification based on the etiology in detail. Now we are going to see about classification of burns based on the depth of the burns. Of course, there are 4 degrees: first degree, second degree, third, and fourth degree burns. So first degree burns is also called as superficial partial thickness burns. It's also called as superficial partial thickness burns. This involves only the epidermis of the skin. This first degree burns involves only the epidermis of the skin. And here the symptoms will be redness, and also patient will have a tingling sensation or a paresthesia. Tingling sensation or paresthesia because of involvement of nerve endings. Because of involvement of nerve endings. So this is about the first degree burns. First degree burns is also called as superficial partial thickness burns. This involves the epidermis of the skin only. Here the patient will have a redness and tingling sensation. This tingling sensation or paresthesia is due to the involvement of nerve endings. And here the redness and tingling sensation will completely recover. Coming to the second degree burns, this second degree burns is also called as deep partial thickness burns. This second degree burns is also called as deep partial thickness burns. And this is caused by, this second degree burn is commonly caused by scald injuries. Scald injuries on exposure to hot liquids or vapor. Hot liquids or vapor. And of course, we all know vapors have high chance of producing severe injury than the hot liquids. And of course, the second degree burns can be caused by flash burns or chemical burns, sometimes contact burns. There is contact with any hot or cold substance can cause contact burns. So in second degree burns, the epidermis and upper part of the dermis and sometimes a part of the deep dermis is also involved. So in second degree burns, the epidermis, upper part of the dermis, and sometimes a part of the deep dermis is also involved. So in this image, you can see the blisters which has been broken here. Here there will be a severe pain and edema. Here there will be severe pain and edema here. And these patients with second degree burns will take at least 2 to 4 weeks for recovery. These patients with second degree burns will take 2 to 4 weeks for recovery. They recover with scarring of tissue, depigmentation of the skin, and contractures can also occur as a late complication. These people with second degree burns will recover in 2 to 4 weeks. And during the recovery, patient will have a scarring of the tissues and also depigmentation of the skin. And the late complication following the second degree burns will be contracture formation, which may require contracture release even. So the surgical contracture release. So this is the image showing second degree burns. You can see the color change, blister formation. There is a edema of the surrounding tissue even. That is clearly visible here. Now coming to the third degree burns. This third degree burns is also called as full thickness burns. This is also called as full thickness burns. This is caused by exposure to flames. This is caused by exposure to flame and also prolonged exposure to the hot liquids or any corrosive chemicals and electric current. So hot liquids, electricity, and also corrosive chemicals on increased exposure time can cause full thickness burns. If the duration of exposure is less, the severity of injury is less. If the duration of exposure is high or more, then the depth of the injury or the severity of the injury will increase. In full thickness burns, as the name itself says, the epidermis, entire dermis, along with the subcutaneous tissue is involved. As the name suggests, epidermis, entire dermis, and subcutaneous tissue is involved in the third degree burns. And sometimes even there can be connective tissue, muscle and bone involvement also in the third degree burns. Muscle and bone involvement can also occur in the third degree burns. So we can see in this image showing a third degree burns over the trunk, anterior aspect of the trunk. You can see a dry, white, leathery skin over here. And of course, there will be some thrombosed vessels are being exposed here. It's not clear in this image. You can see a white, leathery skin here. So clinical features, the patient will present with the dry, pale white, leathery skin. And there will be a visible thrombosed blood vessel. Sorry. And here, the patient will have no pain. The patient will have no pain at all in third degree burns because all the nerve endings in these epidermis and dermis are also destroyed. So there is no nerve endings to conduct the pain stimulus. And these patients will require surgical intervention for sure because there is a high risk of formation of eschar in the truncal area. This eschar will prevent the movement of the chest wall. Patient may need an escherotomy. Not just even in the trunk, but any part of the body, patient will need an escherotomy if the eschar forms. And this third degree burns patient has a high chance of forming eschar as a late complication. Okay. Coming to the fourth degree burns. Here in fourth degree burns, as usual, all the layers of skin like epidermis, dermis, subcutaneous tissue, muscles, and tendons with bones are involved. So in this image, you can see here the bone is being involved. Bone is also being exposed, and also the bone is being exposed, and also bone is also involved. You can see the color change in the bone. This is the fourth degree burns. Sometimes fourth degree burns patient may need an amputation. Fourth degree burns patient may need an amputation even. So this is about classification. Now we are coming into assessment of the patient. How to assess the body surface area involved in burns. How to assess the body surface area involved in the burns. This is an important topic which are supposed to read in burns. This can be asked in MC, even in the NEET exam. We have three methods to assess or to calculate the body surface area involved in burns. First will be rule of 9, also called as Wallace rule of 9, and Lund-Bruder chart, form method. In upcoming slides, you'll be seeing about these individually, but you should know about this three methods to calculate the body surface area involved in burns, and all three has its different applications. Of course, like palm method is very useful in scattered burns. Very useful in scattered burns, and Lund-Bruder chart is commonly used in pediatric age group. Rule of 9 is very commonly used and is easy to use, even commonly used and easy to use. So palm method is commonly used for scattered burns, and Lund-Bruder chart is commonly used in case of pediatric age group burns. And Wallace rule of 9 is commonly used and is easy to use for all. So this is the Wallace rule of 9, total of 100%. Each part will carry 9%. See here, you can see here, the head constitutes around 9%, upper limb 9 individually on both sides, and we have an 18 for the 9 for the upper trunk and 9 for the anterior aspect of the abdomen, and 9 for the posterior part of the upper trunk, that is back in the scapular region, and for the low back you'll have again a 9. So it is anteriorly it is 18 and posteriorly it is 18, and of course both legs constitutes 18, anteriorly 9 and posteriorly 9, and genital pubic region will have a 1%. So totally it is 99 plus 1%. So it is totally 100. So this is Wallace rule of 9. If, for example, only head is involved, then the person will have 9%. And head and right upper limb is involved, it is 9 plus 9%, it is 18%. In NEET MCQs or NEET super specialty, they can be given a clinical scenario and you may be asked to calculate the percentage of body surface area involved in burn. And whether this is important, yes, of course. This body surface area is very important parameter to detect the morbidity and mortality earlier. Okay. If the body surface area involved is higher, the morbidity and mortality is also more. So body surface area involved in burns is very important, and this should be calculated with Wallace rule of 9, and this is very easy thing, and this can be asked in NEET MCQ. Even it can be given a clinical scenario. For example, a 40 years old male or female patient came with a history of burns. On examination, there's a burns in the face, there is a burn involving the right upper limb and in the anterior part of the chest wall. It will be 9 plus 9 plus 9. It will be around 18 and 27. So this is how we will have to calculate it. Coming to the Lund-Bruder chart, this is commonly used for pediatric age group. This is commonly used for pediatric age group here. In the most important thing in Lund-Bruder chart is that it will be very clear and accurate, and there is no, the erythema part is not involved. If there is erythema in some region, it is not involved in, it is not included in Lund-Bruder chart. And this image shows the percentage given for individual part in the children's. This is more commonly used for pediatric age group. Name the method for calculating the percentage of total body surface area involved in pediatric age group, then its answer will be Lund-Bruder chart. Coming to palm method. So this is very effective and this is commonly used for measuring the surface area involved in the scattered burns. Even the chest wall is even bigger. If a patient has a burns in just in this area, not including in the left side. So we cannot give a 9% for this one part alone. Okay, so then we can have it as a, then you can go for a palm method. Here, the size of the patient's palm with the finger is considered to be 1% of the body surface area. The size of the patient's palm with the finger is considered to be the 1% of the total body surface area. If there is only burns here, I'm keeping my hand here. If my palm is being covering this area, this is 1%. If it is here, this is 1%. So this is used for scattered burns commonly. Okay, this is about palms method. Now coming to the zone of burn. Coming to the zones of burn. What happens when the local part is exposed to burning substance? What happens when the local part is exposed to the hot substance? The center part, that is the part which is exposed to the severe or direct contact with the burnt area, or direct contact with the radiation, or direct contact with the corrosive chemicals, will be the zone of coagulation. The burns will cause protein denaturation. The burns will cause protein denaturation, resulting in coagulation. This coagulation is due to protein denaturation. And this lies in the center, and this region is called as zone of coagulation. This zone of coagulation is followed by zone of stasis. This zone of coagulation is followed by zone of stasis, second area. And this zone of stasis is followed by zone of hyperemia. That will be redness over here. There will be redness over here. In a Lund-Ruder chart, this zone of hyperemia will not be considered for measuring the total body surface area involved. So, like factors like a severe form of radiation exposure, or severely corrosive, highly concentrated agent on exposure, a duration of duration of exposure is high. If the duration of exposure is high, sorry for the interruption. So zone of burns, there are 3 zones of burns. It can be either a zone of coagulation, zone of stasis, and zone of hyperemia. Zone of coagulation is the center area. This is due to the protein denaturation, followed by zone of stasis, and followed by zone of hyperemia. So the extension, either the lateral spread or the downward spread, depends upon the nature of the agent that is causing the burns, duration of exposure, and the concentration of the substance causing the burns. So coming to the pathophysiology, so after introduction, classification, and how to calculate the total body surface area, and about the zone of stasis and zones of burn, we are coming into the pathophysiology topic here. So if burns, in case of severe burns, that is total body surface area involved is more than 30%. If the total body surface area involved is more than 30%, this can cause cell lysis. When the cell lysis occur, the intracellular potassium will be released. Intracellular potassium will be released into the bloodstream, resulting in hyperkalemia. Hyperkalemia can cause arrhythmias. Hyperkalemia can cause arrhythmias. And this cell lysis, maybe an RBC lysis, can cause hemolysis, and hemoglobin that is released, this hemoglobin that is released can cause acute tubular necrosis. The hemoglobin that is released gets trapped into the nephron and can cause acute tubular necrosis. Also, when the muscle cells are damaged, when the muscle cells are damaged, they release myoglobin. Similar to the hemoglobin, this myoglobin can go to reach the nephrons and can cause acute tubular necrosis. This acute tubular necrosis in turn can cause AKI, that is acute kidney injury. This acute kidney injury in turn can cause hyperkalemia and arrhythmia. Arrhythmia can cause even death. Okay. And also, because of burns, there will be a locally high increased capillary permeability. The localized vessels or the vessel that is being damaged by the burns will have an increased capillary permeability. So there will be loss of fluid from the intravascular compartment into the extravascular compartment, causing edema. Because of this loss of intravascular fluid, there will be shock. Patient will have a shock. So this is the mechanism of shock in burns. Because of exposure to burns, the capillary permeability will increase. Because of the increased capillary permeability, there will be shift of fluid from intravascular compartment into the extravascular compartment. And this will cause edema. And because of the shift of fluid from intravascular compartment into the extravascular compartment, there will be volume loss in the intravascular compartment, resulting in shock. If treated in appropriate time, this is reversible. If not, then patient will have an irreversible shock or a refractory shock. This can cause death even. And of course, when there is a loss of skin barrier, patient is more prone for infection and inflammation. Because of this, there will be loss of volume. Because of the loss of skin barrier, there will be evaporation of fluid resulting in hypothermia, and also there will be vasodilatation. This also results in hypotension and shock. At the end, towards the end, all this will lead to multi-organ dysfunction syndrome, that is MODS, and patient may have a mortality even. So, how to manage the burns? So, we can classify the management of burns into 3 phases. We can classify the management of burns into 3 phases. Resuscitative phase. This is the thing to be done at the site of burns. If a burns happens in a maybe in an office setup, what we are supposed to do in that office setup itself, the location where the burns occur, and also how to manage it. An acute phase happens or should be done in the hospital setup, and rehabilitative phase should be done in the home setup. Okay. So coming to the management of burns, resuscitative phase, there is management of burns at the site or location of the burns accident happens. First, the rescuer should be safe. If I'm going for rescuing a patient, first of all, I should make myself in a secured and safe place to rescue my patient. And next, I have to remove the patient from the source of injury. Move the patient from the source of injury, because increased duration of exposure can increase the severity of injury. Increased duration of exposure will increase the severity of injury. So as soon as possible, at the earliest time, remove the source or move the patient from the source of burns. And the burning object, if any burning object is in contact with the patient's skin, try to remove it off. try to remove it off. Like if a shirt or a dress is being burning continuously, I'll just make the patient to remove the shirt off. Or any object that is sticking to the skin is burning, just remove it off, so that the duration of contact will be reduced and the severity of injury will also be reduced. And pour a cold water over the burnt area. Pour the cold water over the burnt area. This will reduce the spread of the injury. That is a zone of burns, like zone of coagulation, stasis, and zone of hyperemia will be reduced by pouring the cold water over the burnt area. We can reduce the area of spread. So this is about the thermal burns. This all which we spoke here are about the thermal burns, resuscitation or resuscitative phase in thermal burns. Now, in case of chemical burns, first of all, remove the contact clothing. If an acid has spilled over my shoulder, first of all, remove the contact clothing first. Then wash the skin well with if the agent is spilled out. Wash the skin. If there's still a contact is the chemical is there in my skin, I have to wash it with the copious amount of water. I have to irrigate that area of skin that is involved or that came into contact with the chemical agent should be washed thoroughly. Then coming to the electrical burns, first of all, turn off the current. First of all, turn off the electricity and also use a non-conductor to separate the patient from the source. Even after switching off the mains, switching off the current, be very careful and preferably use a non-conductor to separate the patient from the source. Okay. So now coming to the acute management. Acute management of thermal burns. In case of a small thermal burn, wash it with the copious amount of. Be very generous in washing the area, but with the clean tap water, clean cold tap water. This cleaning of the injured area within 1 minute of exposure will help to minimize the depth of the injury. So cleaning the injured area or exposed area within 1 minute of exposure will help in minimizing the depth of the injury. And always never try to break the blisters because they are sterile blisters. They are sterile blisters when the fluid inside the blisters are sterile. The fluid inside the blisters are sterile. So don't try to break the blister and you yourself don't introduce any kind of infection. And never apply any lotion or powder or some native desi things like ghee or any other sticky agents. And also prevent contamination and cover with a clean sheet. So prevent contamination of the injured area and always use a clean sheet to cover. So two things which you're supposed to keep in mind is that wash with a copious amount of clean tap water because this will help in reducing the depth of the injury and never break the blisters because they are sterile blisters and the fluid inside the blister is always sterile. And don't apply anything that is desi and prevent contamination by covering the injured area with a clean sheet. Now coming to the resuscitative phase of thermal burns. This resuscitative phase will begin by 24 to 48 hours after the injury. This resuscitative phase will begin by 24 to 48 hours after the injury. This can be asked as an MCQ question. This can be asked as an MCQ question even in the NEET exam. So the resuscitative phase of a thermal burns will start by 24 hours, 12 hours, 6 hours can be the option. This can be as a clinical scenario even. A 20-year male patient on exposure to the thermal burns came with the around 30% of total body surface area involved. What is the duration of resuscitative phase for this patient? That may be a question even. So in resuscitative phase, what you will be doing in case of thermal burns? First thing is, of course, it is ABC. It is also called a CED right now. But for now, first thing is to maintain the airway. To maintain the airway, because this injury, this burns can cause airway injury also because of inhalation of smokes and fumes. The smokes and fume inhalation can cause airway injury, which is to be dealt first. And the airway securing is the most important thing. Then cardiopulmonary instability should be addressed. Cardiopulmonary instability should be addressed. In case of lower, below glottis injury, tracheostomy may not be useful, and patient may need ECMO also for stabilizing the pulmonary parameters. And also, this ECMO will also be helpful in stabilizing the cardiac parameters if needed. So, if we are supposed to deal with both cardiac and pulmonary instability, we will go with an AV ECMO. Only in case to stabilize the pulmonary, we will go with the veno-venous ECMO. And of course, hypovolemia. This is the important thing which we are supposed to manage in the immediate post-burns cases. In the immediate burns cases, we should manage the hypovolemia with generous transfusion of IV fluid. Generous transfusion of IV fluid. So the main goal of resuscitation is to maintain the airway, breathing, and circulation. This is the major goal of resuscitation. Okay. So what are the indications for intubation in burns? What are the indications for intubation in burns? This can also be an MCQ question. Can have a clinical scenario, and that can be a question that all of the following are indication for intubation in burns, except, or which of the following is an indication for intubation in, from the above below answers, below options, which of the following is indication for intubation? So, for example, a 40 years male patient came with an inhalation burns. Patient is drowsy. Patient is drowsy and is not that conscious enough. His SpO2 is low, to less than 90, and he has burns over the face and neck. And patient is planned for intubation. Which of the following is the indication for intubation in this patient? Option A, patient's consciousness and patient having burns over the face and neck area. Option B, male patient, something else I can be given as an option. So we should know about the indications for intubation in burns. First will be signs and symptoms of airway obstruction if present. Signs and symptoms of airway obstruction. What are the signs and symptoms? First, patient can have a stridor. Patient can have a stridor, respiratory distress, sometimes paradoxical abdomen breath can be taken. And in case of suspected inhalational injury, this can cause airway edema. This can cause airway edema. And of course, unconscious patient with a poor GCS. Unconscious patients with poor GCS. And acute respiratory distress syndrome. Patient presenting with ARDS. And burns involving the face and neck needs intubation. And extensive burns of more than 40% may need intubation. So these are all the indications for intubation in burns. Indication for intubation in burns. That again I will repeat. The indication for intubation burns are signs and symptoms of airway obstruction like stridor, respiratory distress. And when you suspect an inhalation injury, you are supposed to intubate because this inhalation injury can cause airway edema And this airway edema can obstruct the breathing pathway and trachea. And when the patient has a poor GCS, we are supposed to intubate to maintain the breathing. And if the patient has developed acute respiratory distress syndrome, then we are supposed to go with intubation. And burns involving the face and neck, then intubation will be indicated. In case of extensive burns, there is involvement of more than 40% of the total body surface area, intubation will be the better option. So coming to the immediate measures, after securing the airway, now we are going to maintain the circulation here. First is IV access, preferably a central venous cannula, either in the internal jugular vein or a femoral vein or subclavian vein. Either of these three is preferred. And Foley's catheter insertion is more important because you have to assess the urine output. Urine output is an important parameter. It's an important parameter to assess the adequacy of fluid transfusion. So whatever IV fluid transfusion you are doing, the adequacy of the fluid transfusion or fluid challenge is monitored by urine output and nasogastric tube placement. And of course, in our setup, tetanus toxoid is must. If you are not going with the injection tetanus toxoid, you are medically negligent as per our Indian setup. So this is about maintaining the circulation. Then after securing the airway, breathing and circulation, we are going for history taking of the patient for specific management of the injury. First will be, you have to know the mechanism of injury, either it is a thermal burns or an electrical burns. If electrical, by history, we can conclude whether it is a high output or a low output burns. Either it can be a small household appliances causing a small low voltage burns, or even a high transformer causing a high voltage burns. And of course, time of injury. Time of injury is more important because the depth of injury and the spread of the burns this depends on the type of the injury. And of course, followed by examination. Head to toe examination is must. Neurological examination is must. And distal pulses are supposed to be examined because these burns can cause coagulation of the blood inside the vessel also. That is, intravascular coagulation can occur. Sometimes the vessels can completely denature and can be a cord-like structure affecting the distal flow. In such a situation, patient may need amputation even. And of course, the temperature of the patient, capillary refilling time or capillary filling time is measured, and this will help in measuring the or quantifying the shock. This will help in shock and fluid management. And of course, SpO2 monitoring is must for ensuring the adequacy of airway management. A complete blood count, if elevated, this is elevated in case of infection or inflammation, and electrolytes because of loss of skin barrier, there can be loss of fluid and also electrolytes. And urea is also measured. This shows the AKI at the earliest time. And arterial blood gas analysis is done to assess the PO2, that is partial pressure of oxygen, PCO2, partial pressure of carbon dioxide, and arterial potassium and calcium, sodium values. Chest X-ray is done to rule out the ARDS and carboxyhemoglobin level in case of CO poisoning, carbon monoxide poisoning. So, if there is a constrictive band is formed due to the eschar, then patient may need escharoctomy also at the earliest time. For example, circumferential burns in my arm. That's a circumferential burns, sorry. If there is a circumferential burns in my arm, in my forearm maybe, then this burns will cause an eschar formation in circumferential limb. Okay, this circumferentially formed eschar will cause contraction and can affect the distal flow. So at the earliest time, we are supposed to go with escharotomy. If the eschar is present in the anterior chest wall or in the posterior aspect of the chest wall, this will affect the chest wall expansion and will affect the breathing pattern also. So escharotomy is before the earlier stage in case of eschar formation. So how to do escharotomy? What is escharotomy? This can be a short note even. Escharotomy can be a separate short note even. Escharotomy is nothing but it is a surgical excision of non-viable and dead tissue. Escharotomy is nothing but it is a surgical excision. That's the basic wound debridement of non-viable and dead tissue. So what are the indications? What are the indications for escharotomy? So the common indications for escharotomy are deep second degree or third degree burns. Deep second degree or third degree burns. That too circumferential burns. Deep second degree or third degree burns. That too circumferential burns. And burns involving the thoracic region, that is chest region, because this can affect the chest wall movement. This will compromise the chest wall movement. So escharotomy is done to release the contracture so that the chest wall can expand well during respiration. And also burns involving the lower limb. In case of a circumferential eschar in the upper limb or lower limb, will affect the distal flow. If the distal flow is affected, there can be an ischemic changes in the distal part of the extremities, and even gangrene formation can occur. This is an image shown doing an escharotomy in the chest wall. You can see incisions are made in this region. And coming to the important part of the management of burns, this is fluid resuscitation. So earlier, adequate and appropriate fluid management will reduce the morbidity and also the mortality will be reduced here. So how much amount of fluid should be resuscitated? It should be given either a crystalloid or colloid. What is the volume that is to be given? This is determined by either a Parkland formula or Evan formula and Brooks formula. These are the commonly used, and of these three, the most commonly used is Parkland's formula. So, as per Parkland's formula, there are lots of MCQs from this slide. It should be very clear and very soon enough to read the slides. So, the fluid of choice for or in burns patient is ringer lactate. The fluid of choice in burns patient is ringer lactate, followed by NS. That is normal saline, because the osmolarity of oral is equal to, more or less equal to the blood. That is, the ringer lactate is isoosmolar. Is isoosmolar. It is not hyper or hypo, it is iso. Hence, oral, that is ringer lactate is preferred. So what is the formula here? So for first 24 hours, 4 ml into percentage of total body surface area of burns into patient's weight in kg, weight in kilogram. For example, a 50 kg male with the 40% burns. So here 4 into 40 into 50. It will be 2000 into 4. It will be around 8000 ml. 20. It's around 8000 ml here. So of this 8000 ml, first half, that is 4000 ml should be given in first 8 hours. 4000 ml of fluid should be given in first 8 hours. And the next, on the second part of this 4000 should be given in 16 hours. The second 4000 ml should be given in 16 hours. This is how you have to resuscitate the patient with fluid. This can be also asked in the NEET. Okay, calculate the volume to be replaced in 24 hours for the patient with following details. This can be even asked. So it is 4 into percentage of total body surface area burns into body weight in kg. And now of the total amount of fluid required, half will be transfused in 8 hours, first 8 hours. And the second half will be transfused in next 16 hours. So in after 24 hours, for the second day, for the next 24 hours, the total volume of the half of the first day is required. For example, in this case, 8000 is given on the first day of injury. The next 24 hours, it will be 4000 ml. 4000 ml, it should be given. That is half of the total volume that is given in the first day is given in the second day. And in the second day, you are supposed to start with the colloids. You're supposed to start with the colloids also. The colloid is given at the rate of 0.5 into weight in kg into percentage of body surface area. So here in this situation, 0.5 into 40 into 50. So this will be 2000 divided by, it will be around 1000 here. It will be 1000 ml of colloid is required for this patient. And the rest will be 5% glucose. Rest 3000 ml will be 5% of glucose is given. So this is how we have to manage the patient. That is fluid, resuscitate the patient with the fluid by using Parkland formula. Next is the Brooks formula. And of course, you should know about this formula also. It is 2 ml into percentage of body surface area involved in burns into patient's body weight in 24 hours. In first 24 hours. That is, first half should be given in first 8 hours and the remaining will be in the next 16 hours. And second day, the next 24 hours, similarly, the half of the first day dose is given for the second day. And the colloids here will be given at the rate of 0.3 to 0.5 ml per kg into the patient's body weight into total body surface area involved. Probably this will be undercorrecting the patient. Hence, we are going with the Parkland's formula preferably. Coming to the Evans formula, here the colloid is given on the first day itself. As per Evans formula, the requirement for first 24 hours will be calculated by colloid at the rate of 1 ml per kg body weight and into percentage of total body surface area involved. For example, same 50 kg male with the 40% of total body surface area involved, the colloid required on the first 24 hours will be 1 into 50 into 40. This will be 2000 ml of colloids be given. And coming to the saline, there is also same 1 is to 5 into 40 will be around again 2000 ml of normal saline to be given, and 5% X dose is given at 2000 ml as a fixed dose. This is all for adults. This is for adults. And the requirement in the second 24 hours will be half of the first 24 hours. And it's similar in all three formulas. This is the Evans formula. So we are treating the patient with fluid. Now we are supposed to assess the adequacy of the fluid resuscitation. We have done something and we have to assess whether what we have done is fruitful or not. So assessment of the adequacy of fluid resuscitation. How to assess it? On monitoring the first parameter will be urine output. First parameter will be urine output. The urine output should be more than 1 ml per kg per hour. 1 ml per kg per hour. The volume should be 1 ml per kg per hour. In case of a 50 kg adult, the urine output should be more than 50 ml in 1 hour, more than 50 ml per hour. Then it is considered to be adequate urine output and you are adequately resuscitated the patient with IV fluids. And of course, you should measure the daily weight. Burns can cause catabolism. Post the burns, the patient will be in a catabolic state. And daily weight should be assessed to check whether the patient gains weight so that you're breaking the catabolic chain and getting the patient into an anabolic state. So burns is a catabolic state. This will cause reduced body weight and adequate transfusion of colloids, IV fluids, will break this catabolic state and will make the patient to turn into anabolic state and will make the patient to gain weight. Okay, these are the two important parameters which we monitor, and also vitals. The day-to-day, hour-to-hour, or even minute-to-minute vital monitoring will be very helpful. Heart rate. In case of shock or dehydration, patient initially will have a tachycardia. Heart rate will be high. In a refractory condition, or when the patient's heart fails, he will go for a bradycardia, which can also progress to cardiac arrest. And blood pressure, it will be hypotension. Patient will be hypotensive. Heart rate, in the initial stage of dehydration and injury because of inflammation, the heart rate will be high. If this dehydration or the shock is not corrected, patient can go for bradycardia even in the later stages. And initially, patient will have a tachycardia. Coming to the blood pressure, patient will have hypotension. And of course, central venous pressure monitoring should be done. This will be less. The CVP, the central venous pressure, will be less than the normal value of 5 to 8 millimeter of mercury. So this shows that we are supposed to treat the patient more amount of adequate fluids. And CVP will be directly considered as is indirectly considered as the measure of pressure in the right atrium. And of course, level of consciousness and laboratory values are all measured. And these parameters are useful for monitoring the treatment for burns. Now, the important aspect, wound care. After resuscitating a patient, wound care is more important, or we may lose the patient because of infection and sepsis. If wound is not cared properly, even if your adequate volume resuscitation will not give a fruitful result, because any infection and this situation will cause sepsis. Okay, so wound care should be delayed until the patterned airway and adequate circulation, adequate fluid replacement has been established. Of course, as we saw from 1 to 3 slides, the resuscitation should also be in a stepwise manner. Initially, airway should be managed, followed by circulation, and then fluid replacement. Then we will go with an wound care. There are 2 types of wound care here. One is the either open method or closed method. It is, we have been closing the wound with the adequate dressings. This is to prevent the infection. So, what are the antimicrobial agents that can be used in case of burns injury? So, commonly used is silver sulfur diazine, 1% cream, 1% SSD, that is silver sulfur diazine, commonly called as SSD. And this SSD, that is silver sulfur diazine, is a bactericidal agent. This is a bactericidal agent, and this will have a minimal penetration of eschar property. This SSD has a minimal penetrating effort. So this is very useful in case of superficial burns. Very useful in superficial burns. This is very useful in superficial burns. Okay, now coming to the next drug, that is mefenamide acetate. Either 1 to 5%, either 5% or 10% can be used. And this is a hydrophilic based cream. And this mefenamide acetate is very effective against the gram-negative and gram-positive organisms. Gram-negative and gram-positive organisms. And this diffuses rapidly through the eschar. This mefenamide acetate can penetrate the eschar. So this will be very useful in case of deep burns. This will be very useful in case of deep burns. And 10% mefenamide acetate is the agent of choice for electrical burns because of its ability to penetrate the eschar. 10% mefenamide acetate is the agent of choice for electrical burns because of its ability to penetrate the eschar. Next is the silver nitrate, that is 0.5% silver nitrate, and it is in aqueous form. The advantage of silver nitrate is that more than a bacteriostatic, it is a fungicidal also. It has a fungicidal property also, and it does not penetrate the eschar. It does not penetrate the eschar. So this is also commonly used for superficial contaminated burns. That is 0.5% of silver nitrate. It has both bacteriostatic and fungicidal property. Next is the analgesia. We have to provide the patient with adequate analgesia. There is adequate pain relief is must. Adequate pain relief following the burns is the must. And this is achieved by either morphine sulfate or a fentanyl infusion or a methadone, haloperidol or midazolam. And these all are sedative drugs. These are used for providing, these drugs are used for providing adequate analgesia for this patient. So, how to prevent the infection and wound care? Any wound or burns wound or any kind of wound, initially send a wound culture and or an invasive tissue biopsy. Take a small amount of tissue from the center of the wound and send it for culture growth. And clean the wound daily. Daily cleaning and dressing should be done. And the necrotic tissue should be debrided daily. And the necrotic tissue should be debrided periodically because this necrotic tissue will promote the bacterial growth. So to prevent the infection, first send a wound culture or a tissue culture from the wound. Next is the daily cleaning and dressing, and periodical necrotic tissue removal is also mandatory because this necrotic tissue can promote the growth of bacteria. So wound debridement, how to do? There can be a natural wound debridement can occur in our body itself. Natural wound debridement that will occur in our body itself. Next, chemical debridement. And third is the surgical debridement. So coming to the natural debridement. The body itself will produce enzymes. The body itself will produce enzymes that will dissolve the eschars, that will dissolve the fibrotic tissue. But this will take longer time. This will take longer time. Coming to the chemical debridement, this can be done by enzymatic agents. Commonly, we go with ointments like debridase, etc., which contains peptide urease and other agents. This comes under chemical wound debridement. And surgical debridement is just removing the necrotic tissue by surgical removal or by manual removal. So after healing, what can be done? So we have cleansed the wound, and the wound is free of infection, but the wound is larger in surface area. So there is no infection in the injury area, but the injured area is bigger in size. Then you will go for skin grafting. So what are the indications for skin grafting? Deeper wound, and there is an extensive wound with no infection in it, and there is spontaneous re-epithelialization is not possible or will take time. So we will go for a split skin grafting. This can be an autograft, or this can also go with a fish skin or tissue cultured skin also. Autograft can be taken from the patient's own body. Coming to the temporary grafts. So temporary graft is nothing but it is a biosynthetic. It can be a biosynthetic one, or it can be an artificial collagen-based one, or it can be a completely synthetic one. So biosynthetic one includes skin from the cadavers, skin from the cadaver or porcine. The skin from the cadaver or porcine is removed and treated. Skin from the cadaver is treated and it is used for grafting of the area. And artificial collagens like transite or integra can be used for covering the injured or covering the burnt area. And synthetic things like objects like offsite or biobrain can also be used. So these are the classification of temporary graft. Biosynthetic, where we are harvesting the skin from the cadavers or porcine and treating it chemically and using it for grafting. Artificial collagens like transite or integra, these are the brands which we commonly used. And synthetic agents like offsite and biobrand can also be used. And most importantly, after dealing all these things, nutritional therapy by dietitian is more important for early and faster recovery of the burns patient. So here, for these patients, the diet should be high protein and high calorie diet. Why? Because as we all know, burns is a catabolic state. So to replenish the body, we are supposed to go with a high protein and high calorie diet. Okay, and sometimes, of course, supplementation is also required. And preferred route for diet will be an oral, that is, enteral route is preferred. If patient is having burns over the face and neck, then we will go for either a gastrostomy or jejunostomy, that is, feeding gastrostomy or feeding jejunostomy. And next, if enteral nutrition is not feasible for that patient, then we will go with parenteral nutrition. That is either a total parenteral nutrition or partial parenteral nutrition. But in this condition, like parenteral nutrition, has its own complication and there's an increased risk of infection also. And after all this, psychosocial care. This is an important thing in rehabilitation. This is an important aspect of rehabilitation, nutritional rehabilitation, and also the psychosocial rehabilitation is very important. Here, active and passive exercise should be performed to all limbs to prevent contractures. And of course, You should go with an psychological support and counseling for this patient, and you have to with the disabilities. You have to counsel the patient to lead a life adjusting with the disability. And in rehabilitation phase, the important goal of this rehabilitation is the restart the functional role in the society. Of course, everybody, when we are functional, we will be very active. If you are not doing anything, we will feel lazy and will feel down, of course. So it starts when the patient burn wound is healed and patient begins to start the self activities. And this can start from weeks to months. Some people may heal and may go home after 7 days, or some may need treatment for 3 to 4 months after burns. So after going home, we should make the patient functionally active, should be socially active. So this social activity is very important for their mental health. So this is about the management. Now coming to the complications of burns. So this can be as an emergent phase, that is immediately what can occur, an acute phase and rehabilitation phase. So complications in emergent phase includes arrhythmia, hypovolemic shock. This arrhythmia can be because of hyperkalemia, and hypovolemic shock that can be even a refractory shock, which can even cause cardiac arrest. Coming to the respiratory system, patient can develop pulmonary edema, acute respiratory distress syndrome, and pneumonia. And coming to the renal system, patient can develop acute tubular necrosis. Acute tubular necrosis, this is because of hemoglobinuria or myoglobinuria. Myoglobinuria. And of course, acute renal failure or acute kidney injury with a drop in urine output. Patient can become oliguric or anuric even. Okay, this is about renal system. In acute phase, patient can get infection. This infection can progress to sepsis if not appropriate treatment with antibiotic not started at the earliest time possible. The patient can develop sepsis, septic shock that can be irreversible and can even increase the mortality then. And gastrointestinal system, patient can develop paralytic ileus. This can be because of loss of fluid and also because of alteration in the potassium level. In the rehabilitation phase, during healing, the patient can develop contractures. During healing, the patient can develop contractures. So these are all the complications of burns. And you are also supposed to know about the Curling's ulcer. This is an important MCQ. From here, we will be completing this session. So while dealing with burns, you all are supposed to know about the Curling's ulcer. What is Curling's ulcer is? It is an acute gastric erosion. It is an acute gastric erosion, which is a complication of severe burns. Acute gastric erosion, which is a complication of severe burns. This occurs because of reduced plasma volume. Because of reduced plasma volume and cell necrosis. This reduced plasma volume will lead to ischemia. Ischemia will lead to cell necrosis of the gastric mucosa. Sorry. So, Curling's ulcer is an acute gastric ulcer that occurs because of burns. What is the mechanism behind it? This is because of reduced plasma volume. So, blood flow will be hampered or affected. Blood flow will reduce. This will cause ischemia. They won't reach the tip of the mucosa even. Consider if this is a layer and blood flow is from, sorry, if this is a layer, blood flow is from this direction. When there is a hypovolemia, the region that is below the palmar aspect will have a less flow because of volume loss and shock. So this can cause ischemia and cell necrosis. resulting in gastric ulcer. Resulting in gastric ulcer. So, Curling's ulcer is a complication of severe burns, and it is nothing but it is a gastric ulcer. This is an important MCQ point, and we are completing the session with Curling's ulcer. Thank you. So, if any doubts, people can approach me anytime directly or through the DocTutorials team. Any doubts, please come out in the chat even. If no doubts, we shall end the session. The session has been over, brother. Thank you, brother. Thank you. So, can I come out of that?